First, I want to thank the organizers of this event for allowing me to speak and present our work at this year's conference. Diabetic retinopathy is a major cause of blindness in a working age population, and diabetic macular edema is one of the main causes of visual impairment in this disease. Recently, there have been changes in the way in which this disease is treated. It used to be treated with focal laser photocoagulation, but now it's treated mostly with anti-VEGF injections. Several studies suggest that diabetic retinopathy is associated with a thinner choroid as compared to controls, particularly in advanced disease. However, only a few studies have assessed the effects of anti-VEGF therapy on choroidal vasculature parameters. Given the widespread use of the anti-VEGF injections in treating diabetic retinopathy, it would be helpful to understand the effect on choroidal parameters and associated effects on visual outcomes. In our study, we're trying to evaluate the features of the choroidal vasculature in patients with diabetic macular edema treated with anti-VEGF therapy and their association with visual outcomes. Our study was a prospective observational study that included patients with a diagnosis of type 2 diabetes that were anti-VEGF treatment naive and center-involved diabetic macular edema. We also included patients with moderate vision loss and an A1C less than 12. Only one eye was selected if both eyes were eligible, and the way we chose that is the eye with the worst visual acuity. So for the study procedures, the patients were treated with 3 anti-VEGF injections of ranibizumab as per treatment protocol for diabetic macular edema, and were put on a treat and extend protocol if the patient's central retinal thickness was more than 300 microns based on the spectral domain OCT. We imaged them on the Atlantis at month 0, 3, 6, and 12, as well as having monthly BCVA and spectral domain OCT images. To image the choroid, we use a swept source OCT because it uses, as we know, a longer wavelength than SD-OCT, and therefore is better able to penetrate the RPE, allowing for a clear visualization of the choroid and the chorioscleral interface. We used the Topcon Atlantis, and we acquired a 3D horizontal volume scan. We obtained the retinal thickness and choroidal thickness with built-in automatic software. We used the protocol previously described by our group. So from the SS-OCT scans, we took the ENFOS images, and we used the Brooks membrane for flattening. And then we exported the images from the Brooks membrane to the chorioscleral interface as a stack, and then we processed them further on ImageJ. So the image was binarized so that we could tell the difference between the blood vessels and the surrounding stroma. But as you can see, there's the artifacts from the superficial structures. So the way we got rid of those artifacts is by using the ENFOS slab at the Brooks membrane as a comparison. And here we just removed it from each one of the images in the stack to give us the choroidal vessels. We then calculated the macular choroidal vessel density as the percentage of area occupied by choroidal vessels of each image stack, and then we averaged it for the macular circle, which we defined as a 6 millimeter circle centered on the fovea. For the choroidal vessel volume, we calculated by multiplying the average choroidal vessel density by the macular area and then the average choroidal thickness. So in our study, we were able to recruit 26 patients. 3 dropped out, so we were left with 23 patients that completed follow-ups. This is our table 1, just to show the baseline study characteristics. So we then asked the question, how does the choroid change with the anti-VEGF injections in treatment-naive patients? And overall, we saw that after the 3 injections at month 3, there was a significant decrease in the central choroidal thickness, which remained significant at month 6 and month 12. Something else that we also did was that we separated the groups at month 3. And we separated them based on a prior protocol that considered good responders as gaining 5 or more ETDRS on the ETDRS chart, and poor responders which gained fewer than 5 letters. As you can see, everything was comparable except for age and the macular choroidal vessel density. We then wanted to ask if any of the choroidal indices might be able to predict the response to the anti-VEGF injections. And since the macular CVD was significantly different at baseline for poor and good responders, we were interested in seeing if it might be a good predictor for treatment outcome. So we performed a ROC analysis on all the choroidal indices, and we only found that macular choroidal vessel density was significant in predicting who would be a good or poor responder with a sensitivity of 60% and a specificity of 80%. Before I sum up the results, of course, because any study is not without limitations. So we did have a small sample size, and particularly for the group comparison. And we cannot extrapolate to other anti-VEGF agents because all of our patients were treated with the same anti-VEGF treatment. Population is not representative of different ethnicities, and we cannot accurately assess the choriocapillaris without an OCTA. In conclusion, in our cohort, we found that choroidal thickness decreased with anti-VEGF injections in patients with treatment naive. And we found that macular CVD is a good discriminator of functional response to anti-VEGF treatment in diabetic macular edema patients. So in summary, the study highlights the relevance of choroidal changes in diabetic retinopathy and diabetic macular edema and can help improve the assessment and management of patients with this blinding condition. This also highlights the value of the subsource OCT choroidal parameters in diabetic macular edema, and this may represent a new outcome metric to be used in larger prospective clinical trials. So I just wanted to thank my collaborators, as well as thank you all for your attention.